So good evening or good afternoon, Jaakko. Thank you for being with us this time when we are starting the conference, Dialogical Practices in Psychotherapy. And I would like you to present our participants of the meeting. So Dr. Cezary Rzechowski, you know Czarek from previous meetings. And Czarek, please introduce the persons who are in your team.
Yes, first I should say that I say thank you, Professor Seikkula, that you accepted our invitations. This is a great occasion to think about your ideas and share your ideas in our milieu, therapeutic milieu in Warsaw, but not only in Warsaw, in all Poland, as I think. With us are Agnieszka Politańska and Wojtek Mijas. Both of them are young therapists at the beginning of their career. In my opinion, they are very gifted, talented therapists and engaged in open dialogue approach. But this is start of their practice, and they engaging, interesting in this kind of therapy treatment. As I don't know what the word is the best. As I told, both of them are therapists, and they are working in our team in the unit in Wolski Hospital with young people, adolescents, younger adolescents, and their families. Family approach is very important in our practice, and we accommodated your ideas that we especially are engaged in crisis situation, which very frequent, in fact, in our practice. That's all what I should say.
So Agnieszka and Wojciech, the floor is yours. We, with Czarek, will be listening to you, but your voice will be...
Thank you very much.
Yes, thank you for your introduction.
Okay. So maybe once again, Professor, it's an honor to have you as the guest opening our conference and introducing us to our main topic. I can introduce you in few words, just few words, because you are one of the founders of Open Dialogue approach, the therapeutic approach that has proven to be groundbreaking in working with a social network of individuals in psychological crisis, especially the psychotic crisis. And we would like, for the beginning, to ask you, after almost 40 years of developing this approach, how would you today describe open dialogue approach? What's open dialogue for our guests?
Yes, good afternoon, and thank you for the invitation to be with you here. Unfortunately, I could not be present in your congress, but this is a good way to do it for me. For me, open dialogue is a way to combine the psychotherapeutic work and psychiatric work into same process. And what are the basic elements is that it's a way to organize the system of care in a way that makes possible optimal dialogues in crisis. It includes the idea that we work in team, and perhaps this is different to many other dialogical practices. You can also have a good dialogical practice, for instance, being single therapist, but in open dialogue, because we try to integrate the psychotherapeutic processes and the psychiatric care, for instance, planning the treatment when someone takes contact. This is so important that we work in team. And then in the end, the very basic idea is to have the focus on the relational context of our clients, meaning families and other part of the social networks. And of course, in the end, the idea is to focus on dialogue, not so much trying to find out solutions.
Mm-hmm.
We were also thinking if we could take a step back in history about the beginning of your work, how it started, and maybe you could tell us about the inspiration, what inspired you to develop this open dialogue approach.
Yeah, I was in my background. Unfortunately, it's already more than 40 years, so that it's quite a long history. I had an interest of psychotherapy in psychotic problems, schizophrenia, both in individual psychotherapy and also in family therapy. For instance, I had my training in family therapy early 80s. And when we came to work in this small psychiatric hospital in Lapland in Finland, Keropudas Hospital, we were a team in which we all had an idea that we want to have, as we called, family-centered psychiatry, to include the families into the treatment. And in the beginning, we did it both. We did individual psychotherapy, we did family therapy according to the plan that the staff members had created for each problems. But very early we realized that this is not working. Having this model that the team makes a plan for the patient who has been hospitalized or conducted other way, and we, as a part of the plan, we may have had ideas that there are some indication to family therapeutic talk, and we invited the families to be part of the treatment if we thought that there is a problem. And I think that this was the big problem, because we only could reach between 5 to 7% of the families in the very early years, 80s, before we came and met this innovation that has been produced in this Finnish need-adapted tradition to organize open meeting, to give up the idea that the professionals make the plan for the treatment after the doctor has made an anamnestic interview, after psychologists have made testing, after the social worker has made the things around the social issues of the patient, and then coming together. And now, after hearing this idea that they have generated, we decided to change everything. And what we did, we stopped to have meetings among staff without the client who had been hospitalized. And at the same time, we changed this idea that families are invited to family therapy because of some problem in the family, and followed the idea that families should be invited in any case, in every case, because it's already enough big crisis if someone is hospitalized in the family. And this was the starting point. Perhaps one more issue is that I was my first education, not a prof psychotherapy education, but it was a psychodynamic one. Then I had my training in family therapy, and I have had all the time interest of meeting with individuals, working with families. I did not have any restriction in this respect that we only need to work in one discipline. And this idea of this open meeting actually made possible to cultivate this interest of working in many places. And that's what we started to do. It's a bit funny story, because we at that time, very early years in 1980, we had something that we call schizophrenia summer schools every summer. And this summer, 1984, in August. We had invited the team from Turku with Professor Yrjö Alanen to tell about their story, in which they told about this open meetings idea. And we were so fascinated that when this training stopped in Friday, next Monday, we changed everything. When people asked that how long time does it take to make change, for us it took 1 day, because the doctor in charge defined, his name is Jyrki Keränen, that from now on we no longer will have meetings of planning the treatment without the patient who had been hospitalized, and we work as teams. He said that doctors no longer have the individual anamnestic interviews, but all the interviews are taking place in open forum, and we started to invite the families. This was shortly said the way to this idea of open meetings. At that time, we did not speak about dialogues because we didn't know. It was more a kind of new way of organizing the treatment planning of hospitalized patients.
Mm-hmm. I think that it must have been very courageous. And yeah, how did you find the courage? Because we've read that it's a really effective approach that it leads to withdraw the neuroleptics, and yeah, that's courage that requires courage, I guess.
I think that we were very fortunate because we had the very first experience, very good ones. So that really surprising changes happened with one client or within the family in these open meetings, so that we were encouraged to go on. But at the same time, we started to have pretty confusing experiences. And this confusion, now thinking in hindrance, was about that when we had our training and our thoughts, for instance, systemic family therapy is very much orientated to make changes by the interventions to the families. We still thought that it's our task, but now when we had opened the doors for the families, for the clients to be in the processes, they had a lot to say. How do they want that their family members are taken care of? And if we tried, and we really tried, it was almost tragicomic situation. We thought that our solutions are the best, and we repeated, and nothing happened. And in the end, we need to give up, to say, for instance, in one situation, that this is not working. We do no longer have any good advices to you. And surprisingly, this made the sense. When we changed, the change started to happen. But this was so confusing that we thought that we need to learn more about it. We need to analyze the new system of care, started to make research, and also took the conclusion that we need to have education, because the education we had was not enough working in this new context. And I think that these two pieces, having all the time ongoing education, actually 3 years family therapy training for the staff, which is actually a kind of training of the dialogical practice, and all the time following the outcomes, has made it possible to also to take a kind of steps into a system of care that is a lot of in contradiction with the mainstream thinking that we are used to think.
Yeah, but the effects are really inspiring. Almost 85 to 90%, yes, if I remember correctly, of patients that can return to their lives, to their work after psychotic crisis. That's impressive.
Exactly. They are so good that people don't believe that this is true. And we have been also accused, for instance, one group of Norwegian professors who wrote a bit ugly paper in which they accuse us that this is a fraud. We have excluded the most difficult patients and so on, because this is really so different compared if you are used to think only that the psychiatric treatment is focusing on symptoms of the clients. It's totally impossible to think that 9 of 10 of the clients could return to full employment, their studies after two years. And then when we follow 20 years after, there was huge difference to the results in the treatment as usual.
Okay, so maybe that's the good moment to ask you, because that's one of our most important questions, I guess. What do you consider the main factor in open dialogue approach that leads to changes in patients' lives? Maybe it's not the only one, but
Yeah. I've been thinking about it. Actually, I've written a new book about it. I will not take this time to tell about the book. That in this book, I have 7 responses to that idea. But thinking about this practice in open dialogue, I think that there are 4 very important elements. And the one is that organize the system of care in a way that we can meet immediately with the people within the crisis, and not wait that people become more coherent to be able to be part in the meeting, but meet when everything is open, when you are mostly confused, mostly psychotic, mostly agitated, and meet together with those closest to you, your family members or whoever. And in these meetings, people can become more coherent. But it's not enough. It's very good to meet early. The second point is that in my mind, it's very important to have those most important persons in your life there, even if there would be conflictual relationships or something like that. Because when we meet with people who may be, for instance, in conflict with each other because of the crisis, and they have experienced that they all are heard and respected, they start to listen to each other in a new way. This is so basic idea, to feel being respected and to feel being listened to. And then the third point is that in the meetings, the idea is to have dialogues. And what is so important in the dialogues is that it's really focused mainly on having the voices of each person's heard, and do not aim to find out what is the right explanation to the crisis, or do not try to find out immediately what is the best intervention and conclusion. But in this dialogue, we start to tolerate the situation and share together. Actually, lately, I've been thinking more and more of the importance of sharing emotional experiences. Even so much that in some meetings, maybe that we do not have words. We only have the feeling of sadness or feeling of losing something or whatever has happened in the life. And then in the end, I think that the fourth point is the issue that when doing this, it has been possible to reduce the role of neuroleptic medication, long-term medication in both in psychosis, but also in one study we realized that this happened in severe depression. And in this way to mobilize their own resources and avoid the harmful effects of the medication. I think that these are more or less behind the non-expected good outcomes that we have had in open dialogues.
Yes, I think that being heard is very important, that every voice can be heard. And what is I think also important in this, we experienced it, that some person can be heard for the first time actually on this meeting, and for the first time in their life their voice matter and they can say something. So it seems very important. Yeah, just simply be heard, and then can speak, and yeah, yes.
Yeah, and this is what people often say. When I've done a lot of interviews, follow-up interviews because of the studies, and repeatedly what people say that they took me seriously. And as you said, first time, I don't remember that someone has been so interested on me. And this is like a acupuncture needle that increases resources, huge resources that we have in our embodied mind.
Yes, thank you. And I'm also thinking about the other side, and I must ask if you see any limitations of this method of open dialogue approach.
I don't think that we all need dialogue, and in this way, dialogue for me is the same as breathing in life, and it's senseless to ask what is the indication of breathing. We all know if we do not breathe, we die, and the same is in respect of dialogues. What is the indication of dialogue? Is to be alive. If you do not have dialogue, you will die. It's so simple. So in this way, there is no limits in applying the dialogical approach. Of course, you need to think what are the best ways to do it, what are the best forms, who are the best to be in the dialogues, and so on. But then, of course, there is second answer to your questions, and it is that we do not succeed always as we want. There are failures, there are mistakes that people do. We have done quite a lot of research also about that. And one part of this not so good outcome seemed to be that in the very early meetings, if the team do not succeed to be present in the moments in which people start to speak about the most important issues, it may be that you lose that option if you do not focus on that very carefully, so that it's a lot of question of the sensitivity.
Thank you, because I was thinking about this question to ask you about this successful and an unsuccessful therapy, and you said some about it. If the therapists are not present at the beginning and that they're not there, it can be harmful or it cannot help, right? I'm thinking if you could tell us maybe from your experience, so maybe our guests at the conference can hear an example of an successful and an unsuccessful therapy, maybe from your experience, from your praxis, so our guests can maybe see what mistakes to avoid and what to be aware of.
Yeah, perhaps I could continue with this not so successful situation, and actually this is based on in one study in which we made a comparison. I also myself did one study in which we made a comparison about the situation of the good and poor outcome, and really it seemed to be the case that if the team, for instance, there is one situation that I've shown many times in which the person in the center of care start to reflect on his behavior, or start to reflect on the voices that he is listen to, auditory voices. And if the team did not respond at that moment in a quite radical way, it affected that it never was possible thereafter. Which means that we really need to learn to be sensitive, to be more present in the moments in which people start to speak of the most difficult issues. Because we do not have stories. If I'm in a deep crisis, I do not have a kind of explanation that now I'm in a crisis because this and that happened in my life and I feel so exhausted. But it's my body that is there speaking with all the sensitivity, with the tears in my eyes, with the impossibility to breathe. And these are the moments in which the team need to be present. And if not, it really can lead into a situation of poor outcomes. And other way around, thinking of this good experiences of good outcomes in a quite surprising situation is that if the for instance, thinking of some situation in the team was quite lost in the very early phase of the meeting, but they really were working. We were having a lot of discussions among us to understand what is it all about. And the person, for instance, having in my mind the one family in which two sisters became psychotic at the same time. And they were speaking in a very odd language that was very difficult to listen to. But in some way, in the very first meeting, they had an experience that there is a curiosity to know about their experiences. And even more in this situation, the family had a big problems in the family relationships in the way that it appeared that in the childhood there had been situations in which these sisters did not like especially the behavior of the father, and these things came up into the meeting. But regardless of this, step by step they managed to motivate the people to come and start to work in their own life, and it really went very well in the end for both of them, both for the brother and for the sister.
Professor, you've mentioned the body language, and that sometimes in crisis it's our body which speaks for us, and that was also in the introduction to the Polish edition of your and Professor Ankila's book. And you wrote there that it's a kind of innovation in the development of dialogic practice to include a greater focus on reaction arising from the participants' bodies, and also on tuning physical reactions of the nervous system. And yeah, that was very interesting, and I'm curious if there is any progress in this kind of research or practice. Yeah. Oh.
Sorry. And this is also based in this observation in a research project that we had, and actually we are also continuing about this. And in this research project, we had an interest to look about the synchronization between therapist and clients, and also between, it was a research of couple therapy in which there were a couple, between the couple and between the therapist. And we measured the autonomic nervous system reactions. We look at the bodily gestures and the movements and all the embodied parts of that to find out how do we synchronize in the meetings that we are. In general, I'm really more and more focused on this embodied part of mind in the way that in most severe crises, we really do not, when we do not have ready-made stories about what is wrong with me. So we are living in bodily reactions, and these are extremely important ways. And the challenge to us is to how to share those embodied reactions. So the meetings nowadays are, in my experience, always the meeting in open dialogue has been emotional, but at the moment the meetings I'm involved can be very emotional. And when they are emotional, what happens is that sharing this embodied emotional experience seems to be a very healing experience, quite surprisingly. Even with persons who do not have that much insight, that possibility to formulate their emotional experience into description, explicit descriptions. If we really share the experience, it can be healing. And I've been thinking many times that, for instance, in a situation when the father of the family do not have this possibility, it seems to be a way to start the healing process, even to do it. Actually, quite interestingly, we also realized in this research project that is called Relational Mind. If you are interested, you will find quite a lot of papers written in of this project. We also found out that the change, good change in the life, do not start at the moment of emotional arousal. When we are when we are very agitated, emotional, for instance, sad, and people may cry about this sadness, this is not the moment to make reflective questions or comments and or interpretation. But this seems to be the time to share this, and thereafter we may have possibility to start to ask, how do you explain this? How do you understand this? And this way to combine this bodily reaction to the stories that we create thereafter.
Yes, thank you. I'm thinking, because you are telling us about this process, and when the emotions come in game, and when we can reflect, it's a whole process. And I have a question from our experience, from our place of work. When it's the season of flu, and some people get sick, families get sick, therapists get sick, and I'm thinking, what if we have meetings like it's every week at the same hour, and it happens that therapists are sick. Some of the therapists that are in the sessions are sick, and also a part of family members are sick. And for example, there comes a mother, only a mother without a child, because the child is sick, and only one therapist to the session. And I'm thinking, is it still an open dialogue session if we are one-on-one?
That's a true story.
That's a true story from our experience.
Even if you are sick, it's a part of open dialogue. Yeah. But of course, I followed your question. Yes, in my mind, we have this idea, the psychological continuity, which is very important in good services. And the psychological continuity can be guaranteed that if we have a team, many times it's a two-person, and then there is a doctor who is consulting this process. And of course, it would be optimal if two of them or three of them could be present. But I think that many times in practice there are situations in which one person can be present, and perhaps you can even invite someone to visit this. It's a part of the process. It's a part of the continuation. And I think that one part of the good outcomes is that we really focus on this, guaranteeing this kind of psychological continuation. In my mind, it really is open dialogue, because it's a part of the ongoing process.
So I think that we what I take from your answer is that we need to be open-minded and not very strict, with rules, like not every meeting in the same team if it's not possible, and so on.
I think that it's even fruitful to have some newcomers into the process. So many times it is used if we are in a very difficult processes with our clients. So it's a very good idea to invite someone from outside to sit with us and to introduce a new perspective. Perhaps we could say to him or her that, please, could you make this interview, and we have possibility to be listening to, because it's so different that we follow the interview to conversation in our inner dialogue, compared that I'm all the time occupied in the outer dialogue. And making this kind of changes is very fruitful for the process. And really, I think that it's very good to be flexible and creative in this.
Yes, I think that's it's good to hear because it fits to the environment in many hospitals, that not everyone is available all the time, and sometimes we have to change, and some people in the team has to change, and yes, some people are sick, some people are doing something else, and I think it fits really good in this environment.
It's reality, yeah.
In reality, yes. And I was also thinking that because our team works mostly with teenagers, children, and their families in our medical health center, and we were wondering if you have any experience
to share,
to share with us about working with a teenager in mental crisis. Yes.
Yeah, of course, in the idea of open dialogue, in the idea that open dialogue has been applied in the Western Lapland, it's service for all, for children, for adolescents, and actually nowadays the team that is called adolescent psychiatric clinic, mental health clinic, seems to be the core of open dialogue in the Western Lapland because of their work. And myself also have some experiences of working in this situation. And what seems to be important, for instance, in the problem of young people is to have the social perspective, because this is the part of life in which belonging to the group and being a part of the social network is important than any other most important than in any other time in their life. And very actively they invite people from the school, the nurses from the school, or the social workers, and combine and try to make the focus that this is not only a so-called psychiatric problem, but it includes all the life, and how to include the resources of the friends, and how to invite the friends into the meetings and so on. The challenge, of course, seems to be that sometimes the young people are not so eager to follow the way that the adults are in the conversations, and they may seem to be in opposition to any ideas. They may sit in the corner, hat on in front of their eyes and saying that I'm not so interested about it. And this is a challenge, how to learn to respect their ways of being, their ways of language in the meetings, without trying to force that now you have to speak and now you have to participate. But this really is one way of being in the conversation, and for the team is the challenge that we learn to respect that and follow that way. And if we respect him, the parents may start to have more curiosity about the situation of the young person also.
So it's like also in one of your books titled that respecting otherness, and that leads us to the next question we wanted to ask you about otherness and respecting, about cultural differences. Do you see any influence of culture differences in working in open dialogue with families, with patients?
I think that there are two, of course more, but two elements that comes up into my mind very important. And one of the elements is that, of course, it's very, very important to be very sensitive to the cultural differences, to the national differences, to the cultural differences of different groups of people, to the sexual differences, or whatever, to having the respect of uniqueness of every human being, whatever color of the skin, whatever way of the life that has been organized is. So that having this kind of sensitivity of the cultural ways of organizing the life. Nowadays, for instance, I'm living a part of my life in South America, and concept of family here is very different compared to Finland. Last week we were in an education program and seminar in Mexico, and we met with one lady who had an experience of violence and abuse in his family. She said that this has been going on for generations, and when her daughter started to speak about the abuse and violence that she has been living by the brother of the father, she thought that now it's enough, and she started to speak about it openly. And then she said that this is in all my family. I asked, okay, all your family, how many people do you have in your family? 300. Okay, in Finland we have 4, mother and father and sister and brother. But the concept of family is very different. And of course, this means that there is a lot of resources available and how to apply the open dialogue in different kind of cultures. Finland is very family-oriented culture, even if we do not look at families in that broad spectrum as they do in the South America. But then the other point is that in the meetings, surprisingly, the meetings are very same, regardless of the cultural differences. The meetings that we had in Mexico with this lady, the other meetings that we had in some other type of family problems, and the processes of dialogues are the very same. That was in the beginning quite surprising to me. Of course, I'm quite fortunate because I've been able to sit in the meetings in very different cultures. And for me, it says that the dialogue is global. It's a part of human life, and of course, when we organize our system of care to focus on dialogue, the processes are very much the same. Even if you would choose the language, the words, the wording in a unique way specific to this culture. But you can become sad in the same way. In a meeting with University of Shanghai, that was quite catastrophic when the professionals started to show their emotion and became moved, and it was quite a shock for the other people. But this is what happens in the open dialogue meetings.
We can sum up that dialogue is international.
It is, yes. And of course, it is, as I said, that it's as essential as breathing, so that you do not look at the national differences in breathing as you do not look national differences in this part of being in the dialogue. But at the same time, be very sensitive to the specific ideas in language.
Yes, and when you told us about those countries, I was thinking that more and more people are interested in open dialogue worldwide. And as Dr. Rzechowski said in the introduction, we are beginning our path in open dialogue approach. And we were wondering if you have any advice to therapists taking their first steps in this field.
Yeah, maybe what characteristic we should cultivate or develop.
Perhaps some ideas are very concrete how to organize our work, and some ideas about what would be most important in our training. And for me, perhaps this idea to organize our work in a way that we can work in teams, that increase huge our possibilities to take care of the most severe crises. Most severe crises are paradoxical because they seem to be very risky situation as they are, but at the same time they open doors to resources that were not possible to see before. And this is the way to do it, that we are in teams instead of one single therapist, one single doctor, one psychologist meeting with that idea. And this means organizational changes. And of course, if you are so lucky that you could organize crisis intervention teams so that you can meet people immediately, that would even increase that possibility. And the second part of thinking about the training of us that we definitely need to have the sensitivity that we need in dialogue, perhaps the idea that we already have been discussing, how to learn to listen to it, how to really learn to listen, because people say, yeah, we do that already, and we know that okay, you may listen to in many different ways, but listen to the stories, to the ways of being in life from the point of our clients. It's something that you need to practice and practice all the time. And if you do that in team, that becomes a part of your culture, as Cesare said in the opening, that it's not only a way of organizing, but it also needs a lot of the organizational culture that we cultivate among us.
Thank you very much. I think that we need to slowly come to the end of our conversation, but maybe for the last question, we would like to ask you for the future paths of open dialogue approach, any innovation you see in the future.
What I have been seeing is that the dialogical ideas and also open dialogue ideas has been applied all the time in more and more disciplines. Of course, in the mental health care, in schools, in organizations, in organizational cultures, in social works, and so I think that this what will happen it's happening already now, so that it has been applied in many different fields. Something that started in the core psychiatry. And the second part, I think that it is this idea of embodiment, because it increases resources to survive in very difficult crises. And I have an image that we just have opened the door into a new room, and we do not yet know so much what is there, but there are very good things to learn more about the issue, that how are we bodily involved in the dialogues, and how to take use of this in our purposes to help with people in the difficult crisis.
Okay, so thank you very much, Professor, for the conversation, for lots of ideas and advices.
Yes, and also for the examples. It's also very good for me to hear an example, so I can imagine how it's going. And yeah, I also want to thank you for this conversation. It gave me new ideas and yes,
New perspective.
new perspective. Yeah.
And we hope that someday we will meet in person in Warsaw.
Yeah, thank you very much. I'm so pleased to meet with young people. You are the future. Thank you for this conversation.
Thank you.
Thank you very much.